Good evening. Welcome to this month's parenting session on medical and mental health impact on COVID in kids. My name is Gina Marie Bounds. I'm the Vice President of the Pediatric Service Line at Cohen Children's Northwell Health. I am joined tonight with an expert panel of physicians in primary care pediatrics, pediatric emergency medicine, pediatric cardiac critical care, and pediatric psychiatry. Please allow me to introduce our panel. Our Vice Chair of Pediatrics, Dr. Fagan. Our Associate Chief of Pediatric Emergency Medicine, Dr. Williamson. Our triple boarded pediatric intensivist, Dr. Capone. And of course, our all-star AVP of School Mental Health and Director of our Pediatric Emergency Psychiatry and the Behavioral Health Centers, Dr. Foyer. Thank you all for joining us tonight. Before I begin, I'd like to go through the run of show. Tonight, we will be hearing a quick update from our panelists discussing what they are currently seeing in their specialties surrounding COVID and related topics. Then we will move on to a 50-minute panel discussion and take questions from the audience. You may type in your questions in the Q&A function and we will do our best to get to them all. I realize some of these topics can be politically charged and biased. Our goal tonight is only to give you the facts of our experience, or rather the facts of the experience of the physicians here tonight. We will not be sharing our personal opinions. We're just trying to share our experience and answer your questions to the best of our ability to allow you to make your own decisions. I would be remiss if I did not acknowledge the chaos surrounding the New York State mask mandate. That being said, the legal proceeding surrounding New York State ruling and appeal is not in our wheelhouse, and we will not be commenting on it tonight. All right, so let's get started. Dr. Fagan, will you please kick us off?
Thank you, Gina Marie, and good evening, everybody. And we appreciate you all taking some time out of your evening to spend it with us. So as Gina Marie said, I'm vice chair for our primary care pediatric network at Cohen Children's Northwell Health. And I want to just give you a sense of what's going on in terms of COVID numbers at a high level, as well as what we're seeing in our practices, and then also talk a little bit about COVID vaccines around the 5 to 11-year-old population and what's going on currently with testing in schools. And I'm going to do this in a very efficient manner. Next slide, please. So this is data that is supplied on a weekly basis by the American Academy of Pediatrics and the Children's Hospital Association of America. And cumulatively, since the beginning of the pandemic, we are now at over 10.5 million cases of COVID-19 in children under the age of 18. And that represents about 18.5% of all the cases in the United States. This data that I'm showing you is through January 20th, which, if I'm doing my math correctly, was last Thursday. And in the week prior, so from January 13th to the 20th, there were over 1 million new cases of COVID-19 diagnosed in children. And that represented over 25% of all the total cases during that week. Just to give you some perspective around that number, when we were dealing with the peak of the Delta variant, which was really in children towards the latter part of the summer, at one point we were about 250,000 cases in a week. And now just last week, over 1 million. Next slide, please. So this is really just a summary of what I showed, so we'll skip over this. Next slide. Thank you. This is a nice slide. This takes us back from the very beginning of the pandemic, looking week by week at the number of cases diagnosed in children. The first real peak that we see, which is kind of in the middle of your slide as you go from looking at it from left to right, was after the holidays, the end of 2020 into 2021. And we had a peak of about 211,000 cases. And then we had introduction of vaccines in the general population, and that did have an effect on children. And then people under the age of 18 were allowed, began being immunized, and we had a nice decrease, and we kind of bottomed out in the beginning of July with that number of 8,400 cases. And then we have that uptick of the Delta variant, which I just mentioned. And then we can see what has happened with the rise of the Omicron variant to the point where we had over 1 million cases in children last week. Next slide, please. This is more local data. So what I just showed you is data for the United States. This is data looking at New York State, and again, cases in children. And we're going on the left-hand side of the slide, starting at the beginning of 2021, and really going through the past 12 months to where we are today in 2022. This data is through January 8th. Basically, the dotted line, the dotted black line are all children from age 0 through age 18. And again, with Omicron and the holiday surge, you can see that uptick. Next slide, please. The biggest increases week by week have been in the younger age groups, as you can see here. In the 0 to 4 group, over a 36% increase from the week of 1/1 to the week of 1/8, and then in the 5 to 11-year-old group, a 58% increases in the number of cases. And then you can see the other age groups. And again, this is New York State data. Next slide, please. I'm not going to talk about hospitalizations or emergency room visits, as I will leave that to my colleagues who work out of our emergency room and out of our intensive care unit in Cohen Children's Medical Center. Just to give people a sense of where we are now with vaccinations in the 5 to 11-year-olds. And this data starts from November 3rd, which is right around when the vaccine was approved for this age group. And currently we have immunized with their initial dose, so not fully immunized, but initial dose, about 28% of the 5 to 11-year-old population in the United States, and that's about 8 million children. But you can see on the right-hand side, after an uptick early on, we've really kind of leveled off, and in some cases have gone down a little bit in how many children we're immunizing on a week-to-week basis. So we started this over 2 months ago, almost 3 months ago in this age group, and only 28% of children in this age group have received 1 dose. Next slide, please. So just recently, there's been some expansion in who can get additional vaccine doses, as known as boosters. So 16 to 17-year-olds who completed the Pfizer primary series, that means 2 doses, should receive a booster dose of the Pfizer vaccine 5 months after completion of the primary series. And remember, Pfizer is the only vaccine at this point that is licensed for use or emergency use authorization for people under 18. Now, 12 to 15-year-olds who completed the Pfizer primary series are also eligible for a booster dose 5 months after the completion of the primary series. And 5 to 11-year-olds who are moderately to severely immunocompromised are now eligible for a 3rd dose to complete their primary series, and that can be given 28 days after the 2nd dose. So there has been recently some liberalization in who can get booster doses and who can get additional 3rd doses. Next slide, please. So just quickly, some of the benefits of immunizing this age group. Overall, the efficacy, and this data I will just point out is prior to the real rise of Omicron, but testing on the initial strain and even with the Delta variant, the vaccine is about 91% effective against lab-confirmed COVID-19. And so what does that mean? That means that, there's still 9% of children that could get a breakthrough infection. And again, these numbers are a little lower now with the Omicron variant. But the point is, no vaccine is 100% preventing you from getting the infection, but you're not, most likely you're not going to wind up in the hospital. You're not going to wind up in an ICU as my colleagues deal with on a daily basis. Another important benefit of immunizing this age group is to prevent the occurrence of MIS-C, which we're going to hear about in some detail, and we're starting to see more cases of MIS-C given the rise of Omicron. Maybe most importantly, vaccination in this age group prevents transmission from children to other household members who may not be vaccinated or members in the community. Next slide, please. So risks of vaccine, the most common adverse events were similar to or milder even than those in teens and adults. And that could be pain, swelling, or redness at the injection site. In rare cases, fever, fatigue, headache. Now, you've probably heard in the news about cases of myocarditis or pericarditis following vaccination. These cases have been reported to be mild, as my colleagues will speak to, and they are much, much milder than the myocarditis or pericarditis that can result from a COVID-19 infection. Next slide. So one question that we're asked a lot about is, I've had COVID. Do I need to get the vaccine? And the answer is very simple. The answer is yes. We don't know what levels of antibodies are protective. If you got infected with the original strain, you are still more vulnerable to the variants. And at this time, there's no FDA authorized or approved test that can tell us what is an appropriate or a protective antibody level. I will add that unvaccinated people who've had COVID are more than 2 times more likely to get COVID again than people who have been vaccinated. So if you've had COVID, you still should get vaccinated. Next slide, please. Rapid antigen testing, we're using this a lot to keep our schools open, to keep students in schools. We get results quickly, in 15 minutes to a half an hour, depending on the test. And they are somewhat less accurate than PCR tests. But if a person tests negative with an antigen test and is suspected of having COVID-19, meaning like they've had symptoms or there's a high likelihood they came in contact with somebody and they test negative on a rapid test, then you go to get a PCR test. But if you're symptomatic, given the amount of Omicron we have in our community, and you test positive on a rapid test, that is something that is, you can believe that result at that point. Next slide. Recently, the CDC shortened the period of quarantine to 5 days, and the New York State Department of Health on January 10th followed suit. So we talked about masking, and masking is still required and recommended. We'll see what happens with yesterday's ruling, which has been already appealed by the Attorney General. So the mask mandate stays in effect until the Court of Appeals rules on this. So what's new with quarantine? For in-classroom activities, if you are a fully vaccinated student, teacher, or staff, and you've been exposed to an individual with COVID-19, you may continue to attend work or school regardless of your booster status, but you should be quarantining outside of school. The caveat to this is you're asymptomatic. So you're exposed, you're fully vaccinated, you have no symptoms, you can stay in school. And just a reminder, fully vaccinated means 2 weeks after receiving your second dose of the Pfizer or Moderna vaccines. For, again, Pfizer only 18 and under, Moderna 18 and over, and fully vaccinated with 2 weeks after 1 dose of the J&J vaccine. Extracurricular or after school activities, individuals 12 or older who are eligible for a booster but not yet boosted and who have been exposed to an individual with COVID-19 cannot participate in extracurricular or after school activities. And aside from going to school, which you can still do, must adhere to a 5-day quarantine at home. Now, if you've not been vaccinated and you have not completed a primary vaccine series and you've come in contact with someone with COVID-19, you need to quarantine for 5 days, and you shouldn't be in school since you're not vaccinated. isolation. So that means you tested positive for COVID, right? So you need to isolate for 5 days, and that's regardless of your vaccine status. If you have improving symptoms or resolution of 5 symptoms, you can return. But if you're not feeling well, or the symptoms are lingering, you should extend your isolation period past that 5 days. Next slide, please. This, I think, is my last slide, and I just wanted to spend a second on flu. And there's been a term in the literature and also in the lay press called flu-rona. So that's that combination of, well, how do we know? Does somebody have flu? Does somebody have corona? Because the symptoms can be very similar and can overlap. I will tell you that we are seeing very little flu right now. This graph is something that is put out by the New York State Department of Health on a weekly basis. The big line there, the brown line, that represents the flu season from 2019 to 2020. That was a pretty bad flu season. The green line on the bottom of the graph along the x-axis, that was last year's flu season. We didn't have any flu in 2020 and into 2021. No flu at all. The red line is this year's flu season, and we were concerned. You can see what happened basically from right after Thanksgiving through right before Christmas. There was this huge uptick, and we were concerned that that curve was going to continue to go up and mimic the terrible flu season we had in 2019, 2020. That thus far doesn't seem to be the case. As you can see, there's been a decrease in flu cases throughout the end of last year into the beginning of January, into the middle of January. We don't know if that's going to go up again. We hope it does not, but it's not too late to get a flu vaccine if you haven't, especially if you have young children, they're in childcare settings or in congregate settings with other children. It's important to get the flu vaccine. Next slide. Again, I want to thank everybody for their attention, and I'm going to turn it back to Gina Marie, and I guess we're going to take questions at the end. Thank you.
Thank you so much, Dr. Fagan. Right now, I'm going to turn it over to Dr. Williamson, who's our pediatric emergency medicine specialist.
Thanks, Gina Marie. Thanks for having me. Again, I'm the Associate Chief in the Pediatric ED at Cohen. So I'm going to be giving you the emergency department perspective, mostly from a physician perspective, but also I am a parent of kids in the local school district. So I'm going to give you just some tips and things that people have been asking me about when to come to the emergency room and such. So we can go to the next slide. Dr. Fagan talked about numbers a little bit. I wanted to talk about our numbers specifically at Cohen's. The volume in the ED has been a roller coaster in the last 2 years. We did our first testing for COVID about 2 years ago, and it's been up and down since, but we haven't seen numbers as high as we did other than the last 3 weeks. So this is our percent positivity of COVID. So these are the kids that we tested and tested positive. Remember, the positivity rate in the emergency room is always higher than the general community, just because kids are coming into the emergency room usually with symptoms. And we see that, early in December, late November, our positivity rate was about 5%. And our busiest day, January 2nd of this year, we hit a positivity rate about 61%, showing that, 61% of the kids that we tested on that day, when our volume was very high, tested positive. We have seen that peak come down. Most recently, our positivity rate was about 30%. You can go to the next slide. So, what does this mean? Obviously, the numbers are high. No one wants their child sick, but what does it really mean in terms of severity? And the way we kind of judge this in the medical field is hospitalizations, ICU admissions, and death. Thankfully, pediatric deaths are very low. The rate's less than 0.02%. Someone in the questions ahead of time had asked about deaths from COVID in the pediatric age group under 18. The numbers are about a little over 1,000 so far since the start of the pandemic. Just as a comparison, the deaths in pediatric patients from flu every year range from like 150 to 200. So definitely higher than flu. And a recent study that just came out showed that most of these kids have some major comorbidity, the most common being obesity. But back to this graph, I'm not going to go through the details. I just want you to look at the end part, the last few weeks, showing that the hospitalization rate, specifically for the yellow group, which is the 0 to 4 years old, has dramatically increased. And we've seen that in our own hospital. There's many reasons thought for this. One of them is just being that we can't vaccinate these kids under 5 yet. You can click in. This is our hospitalization rate at Cohen's. So just so everyone's kind of aware, before December, we were seeing maybe 1 or 2 admitted kids with COVID every day. And these are our numbers in the last month or so. So we hit a peak at the beginning of January, almost 60 kids admitted for COVID. We're down to about mid-20s now. And the questions we always get is about comorbidities and if they actually have symptoms of COVID. So the first question about comorbidities, about half of our kids have some sort of major comorbidity, but half do not. About 86% of our admissions are unvaccinated. Obviously, this includes the younger kids that cannot get fully vaccinated. And the other question is, are they just testing positive and there for something else? So obviously we have a handful of kids that, for example, are admitted for appendicitis and just test positive. But 80 to 90% actually have symptoms of COVID. The reason why we can't give an exact number is sometimes it's so hard, right? So the kid's admitted for dehydration, but they have COVID, right? So technically the admitting diagnosis is dehydration, but they wouldn't be dehydrated if they didn't have COVID. So that's why there's not exact numbers to this, but I'll tell you, most kids are admitted and have symptoms of COVID. So remember, these kids are mostly unvaccinated and mostly have comorbidities. We'll go to the next slide. I put this in for symptoms. Most people on the call already know a lot of this. In general, you usually get symptoms about 5 or 6 days after some sort of exposure. Symptoms are typically more mild with Omicron. Kids can have the low-grade fever and congestion. There is no way, been asked this 100 times, but there's really no way to tell COVID from other viruses. And that's why we strongly recommend testing for anyone with symptoms. Kids can have fever, headache, body aches. The one interesting thing about Omicron that we didn't really see before is it definitely has a predilection for the upper airway. So you've probably had kids with, a raspy voice or sore throat. The one thing that we definitely have seen in the emergency room is a lot of cases of croup. I'm sure some of your kids have had croup before. Remember, it's kind of a virus affecting the voice box, and kids can present, with a barky sounding cough, or that noisy sound when they're breathing in. And we've definitely seen this. We don't know the exact reason why, but we've definitely seen this more with Omicron. And this partially explains why we've had a lot of admissions in the younger group, is that we've seen a lot of croup with this new strain of COVID. So testing, Dr. Fagan touched on this a little bit, and this doesn't necessarily have to do with the ER, but I get this question from my friends and parents every day, so I thought I'd spend 1 minute talking about it. So you have your rapid diagnostic tests, your RDTs, and your PCR tests. So PCR is what we do from the emergency department. Obviously, these are better tests, but you have to come to emergency department or an urgent care to get them. The RDTs are the antigen-based tests. So you have to have enough virus in your nose when you swab for it to test positive, but they're good because you can do them from home. I think like almost 30 companies or tests are approved now for EUA under the CDC. They usually come with 2 in a pack. These are the ones that you probably got from your school district and that the government is now sending out. And, the most important feature of this is that you have to know when and how to use them. And obviously I preface this with, you can always talk to your pediatrician if you have any questions, but I'm just going to give you some guidance. You can click to the next one. But basically it's how to use them. You have to know your probability of having COVID. So these are just some general guidelines for you. But if your child has symptoms and you do a rapid diagnostic test and they're positive, it's positive as of now with our current rates. If it's negative, they recommend just rechecking in 2 days. Same thing with if you have some sort of exposure. So if you're moderate risk, if you have a real high risk exposure, like someone in the house, but your child is asymptomatic, you can do this antigen test. Same thing, if it's positive, it's positive. It's negative, recheck in 2 days. And still, if it's negative, you want to monitor for symptoms and recheck. This is why a lot of these tests come with 2 in them, so you can recheck after 2 days if they're negative. And the last situation is just a low risk of transmission. So it's a kid that, was maybe exposed in school or, some sort of sport exposure, and you can test them. This is probably most people on Long Island right now. But if you want to test for this reason, remember, these are asymptomatic. It's kind of opposite. If you're negative, you're probably negative. But if you're positive, they want you to recheck. So hopefully that was a little bit helpful. I mentioned this, I'm only going to talk for 2 seconds about this. This is my non-COVID section. Dr. Capone, who's our expert in these syndromes, will talk more about it, but I just want to talk from the emergency department perspective. MIS-C is this post-inflammatory COVID condition that we see a few weeks after kids have COVID. And it doesn't matter how severe your COVID was, or even if you knew you had COVID, but kids are coming in really sick. And remember, this peaks a few weeks after having COVID. So we're starting to see an uptick now. I think we've seen 11 or 12 in the last 2 weeks. And these kids are coming in very sick. So while we talk about rates of hospitalization and death and how sick kids are with COVID, this is something else you have to weigh in when you're making your decisions about your kids, that this is a possibility. And the reason I bring it up here is that if you if any of your kids have, prolonged fevers, more than 4 or 5 days with belly pain or vomiting, those are the main symptoms, and you know that they had COVID a few weeks ago, it's definitely worth talking to your pediatrician and seeing if you need to come into the emergency department for evaluation. So remember, prolonged fevers and a lot of GI symptoms. And then really quick, this post-vaccine myocarditis, I bring it up here just to say that, if your child was vaccinated, specifically these teenage boys, and you have chest pain a few days later, it's worth coming to the emergency department. Remember, these kids all do very well, but it's worth being evaluated. Then we can go through treatment. You can click through here. So people ask me every day, my child tested positive. What do I do? What can I give them? The most important thing is, when do I need to bring them to the hospital? And you can for the most part, in your healthy kids, treat them as any other child or any other virus. Is that, if you're concerned about their hydration, if you're concerned about how they're acting or about how they're breathing, obviously bring them to the emergency department. But if they're, just are acting like they have a cold, you keep them at home and follow your quarantine and isolation precautions. The next one, I think, is inpatient medication. So there are other medications. We get this question a lot, but they're for kids that are sick enough to need to be hospitalized. You want to go ahead, follow your quarantine, which I talked about. And the last thing is just, you click one more, is that monoclonal antibodies are the IV treatment, and the new oral Paxlovid is available. These are 2 treatments for COVID in anyone that's 12 and up. Over 40 kilograms, and they have to have some sort of, high risk medical condition. But these are available to anyone with high risk. So if your child you think they qualify, just speak to your pediatrician and you can get referred. We do the monoclonal antibodies currently in our emergency department. So what else could I do? Everyone's going to touch base, touch upon this during the talk, and Dr. Fagan mentioned it a little bit, but obviously I would recommend vaccination for anyone that's over 5, or if you're up for your booster. I can, continue to encourage social distancing and mask wearing. Obviously, this is a pretty heated debate the last couple of days at least, but we know that masks do help prevent spread. They do help contain the respiratory particles. So let's, until our rates come down a little lower, let's do all we can to protect our kids, especially the young kids. We are optimistic about our rate of transmission, and our emergency room numbers have definitely come down in the last week or so. We want to keep this level. Thank you for joining this and for taking part of this and listening, and we'll take any questions at the end.
Great. Thank you so much, Dr. Williamson. And a special thank you, because I know everyone say the past couple of months, Omicron has been crazy and surging the hospital, but the reality is the hospital's been surging since last June, when we had that crazy flu or virus season in the summer. So it's been a rough 6 months in the emergency room. So thank you for all your efforts. I'm going to turn the discussion over now to Dr. Capone, our cardiac intensivist. Dr. Capone.
Thanks again for having me. So I am one of the pediatric cardiologists. I'm also dual boarded in critical care, and I've been one of the intensivists throughout this pandemic. And I'm co-director of the comprehensive MIS-C and COVID follow-up program here at Cohen's. And so we've seen a lot of graphs about waves and case numbers, and I'm I get asked about what these kids look like in the hospital, after the hospital, how do they do? And so taking you to a different, again, you're seeing so many graphs, so many data, but waves of things. So this graph, particularly from the CDC COVIDNet, is looking at laboratory confirmed COVID-associated hospitalizations. This is by week from March of 2020, when this all started, at least in our tracking, to January 1st of this year. And so similarly, with the waves that you saw of cases that both Dr. Fagan and Dr. Williamson had showed you, this is similar waves in terms of hospitalization. In red is the 65 and above population. In yellow is the 0 to 4 year olds. And in this grayish color is the 5 to 17 year olds, so our pediatric population, which is predominantly represented at the bottom. And you see our waves, that is our original strain. We had some Delta that kind of came through. And now we have this surge over here, which is Omicron. And it is something that everyone's kind of keeping a close eye on. But right now, the data seems to be very similar. The hospitalizations are up, but kids are in general doing well. And I put the numbers here to kind of give you a sense of the differences in cases that are hospitalized between kids and adults. So taking these hospitalizations and asking, so when you are hospitalized now with COVID, what does that morbidity look like? Still trying to draw from the general pool. Again, this is the CDC data, just looking at in-hospital deaths for the 0 to 4 population here, characterized by age. And so there's 5 to 17, 18 to 49, and so on and so forth. So the blue line is relatively very, very, very small. If you look at the actual percent count, and again, this data only goes through November, so we're missing December, we're missing some Omicron, where this is to, again, something to be thought about differently. And again, it's different from some of the other numbers that are quoted in the hundreds, because those hundreds don't necessarily include those that are associated, quote unquote, hospitalizations and have other kind of variables attached to that data. But this is from, again, a different way to look at it. 14 patients, 14 of the 0 to 4 years of age out of the millions of children have died from, again, March through November. But that is not the only endpoint. You don't want to see your kid in a ventilator. You don't want to see your kid with vasoactives. And so we can look at this graph again, March to November. So again, missing some data. But of those hospitalized, it's less than 1,900. That's a total count here of 0 to 4, 113 needed a ventilator in this data set from the CDC, which the blue in terms of a percentage here looks like a 6% looks to be significant. But when you actually parse out the numbers, yes, there are people who need a ventilator. There are kids who die in that 0 to 4 age group, but this is in relation to not only all those who test positive, but the millions and millions of children who are out there that we're not talking about, who are fortunately remaining out of the hospital and healthy. So what do we see at CCMC? We see waves, more waves. That's the theme. So gold here is COVID for us, starting in March by week in 2020, and then going through January 29th. So again, this is ahead of us. We're missing some data from the next couple of weeks. But this is where it all kind of parses out. And so yes, COVID in general, hospitalizations, this is the case hospitalizations for COVID at CCMC, right? So if you look at this is end of 40 back in March and April, coming now here to probably what the highest case is what we've seen, but again, it's not necessarily surprising given how infectious that we're hearing Omicron is. The red is our MISC, and you see that kind of starts to lag where the peak starts, and that's the 4 to 6 week that we worry about, and that we say that is a different kind of disease associated with COVID that has some myocardial involvement, that has more likely to have shock, that puts kids sick in a different way. So these are the hospitalizations, these are the cases. So how do they do? So at Cohen's, at least for the kids that we follow, looking for cardiac involvement, so speaking to the COVID-related myocarditis, at least in our hospital, we've only had 1 to 2 patients total over the course of the year for just COVID myocarditis. And then anybody who was hospitalized for COVID, who we were concerned just was hospitalized for COVID in the ICU for any other reason, was followed by us, and there was no persistent cardiac abnormalities on follow-up after discharge for COVID. The cardiac evaluations for the non-hospitalized children infected with COVID that had come to us because of the concern that they could have cardiac morbidities, especially similar to the adults, again, have all been normal. And this came from the initial MRIs and the imaging that people were talking about in the news and varsity athletes. And we don't see that on our children here. So presently, we're encouraging pediatricians to assess basically how kids are doing, how sick they are when they first present. Are there any cardiac symptoms? If there's no cardiac symptoms, then a pediatrician can clear. If there's athletes that need kind of NCAA varsity sports clearance, or you have any kind of moderate or severe symptoms, then getting a cardiac referral for peace of mind, given that there are some kids who do have cardiac sequela in the literature out there after just a COVID illness, like that could be moderate, is reasonable, and that's what we are here for. But what about MIS-C? So currently we follow 117 children after treatment and hospitalization for MIS-C. And the children were sick, there's no doubt about it. They were sick on presentation. There are 52% of them, half of them at least, with both imaging, so echo evidence of heart dysfunction. They needed blood pressure medication. It required an ICU admission. So these kids are sick. Like that's 50 kids that we've talked about already. And that's like, if we're using numbers, that's the 50 was what we just said were hospitalized recently. So it's a lot when you think about how sick they were, but all kids went home. There were no in-hospital deaths. There was no patient who required life support, at least at Cohen's. All kids that we took care of, thankfully, had normal heart function by 6 months after discharge. There was no heart damage or scarring on MRI that they were talking about with COVID myocarditis. And essentially, we're able to return them to sports around 8 weeks from discharge. And we've been publishing on that data. And again, here is the reference for where we're putting that out there for the community. So what about vaccine myocarditis? So this is the table that gets everybody, well, up in arms, so to speak, about, well, there's heart damage associated with it. So difficult to kind of read, but they're looking at the age group here, Pfizer and Moderna, age breakdown 12 to 15, 16 to 17. And they're comparing the case rate to a background incidence of myocarditis. Upper limit of the incidence is 2 cases per million person, 7-day risk period. And so when you look up at top, there is anywhere between 5 to 70 cases per million in the 16 to 17 age group here. So there is a incidence that's higher than the incidence of myocarditis in general, both for COVID-related and non-COVID related myocarditis. So yes, there is, again, that association that you see here, but it's very, very, very rare. We're talking about millions in terms of the incidence. But I get asked, what does that look like? What does this heart damage look like? And so Dr. Mitchell, I had her picture here. She was the person that works with me at the Cohen Children's Heart Center, and she has published on this. This is 139 cases across the country. We contributed about 20 to this. And in terms of what they look like, they do come to the hospital for the ones that do, and the ones that do, 18% are in the ICU. So they're considered to have that mild course that Dr. Fagan was mentioning earlier. They're not intubated, they're less likely to need the blood pressure medicine. But 70% of them did have an abnormal heart rhythm. They had an arrhythmia, and 77% had heart inflammation on MRI, something we did not see, or I did not say that they had in MIS-C. And so the conclusions here that most cases of suspected COVID-19 myocarditis occurring in persons less than 21 years have a mild clinical course with rapid resolution. They weren't in the ICU, they went home fairly quickly. But there are abnormal findings on imaging that is suggestive of heart inflammation and scarring, and we have to evaluate what that means in the long term for these kids, and this long-term data are forthcoming. In general, they're healthy. In general, they go home. But we don't know what this means in the long term. That's true of this. That's true of the current Omicron wave, but from what we've seen so far, kids in general are doing well, and that is the take-home message for this. For everybody who is or has some concern, Dr. Mitchell and myself see patients after hospitalization for MIS-C, for COVID illness, and if you want to return your kiddo to varsity level sports, or they're getting ready to play college sports, just need some peace of mind or reassurance, we're here for you as well. And just wanted to thank you. And again, questions at the end.
Great. Thank you so much, Dr. Capola. And you're such an expert in this field, and I really appreciate you sharing your experience and research publications with us. So we have 50 minutes left. I'm going to turn over to Dr. Fourier, who is our resident expert in mental health.
Hi, everybody, and thanks so much for sticking with us tonight, going through a lot of information. And I know impact of mental health of kids through and how this pandemic affected that has been a very important and very complex topic. And I just want to start by saying that despite all the headlines in the news talking about how much our youth mental health has been impacted through the pandemic, I just want to highlight that a lot of the issues that we're seeing now really are not new. And there were many areas of concern for youth mental health even before the pandemic. And our kids have been in environments even before the pandemic where, factors around climate change, around technology use, around commercial exploitation, around marginalized social groups or political climate, kids with developmental disabilities, having healthcare disparities, and all, even before the pandemic, having a workforce crisis in mental health specifically, have had large areas of concerns about youth mental health even prior to the pandemic. And the pandemic has added to that, no doubt. And it has done that in many, many ways. And really through the impacts on families, where many families have dealt with a lot of loss, a lot of stress, a lot of difficulty, a lot of parental stress, parental depletion of resources for parents, capacity to help support their child, and sort of zapping of parental resilience because of all the stress that adults have also endured in these 2 years. And then having economic impacts, food insecurity, housing issues, unemployment, all the ways that families have been impacted financially. No doubt in our minds that schools and the way schools have operated in the last 2 years had an impact on kids and their mental health. Not only the education loss that studies are coming out about that kids have endured, but even more important, perhaps, some of the social and developmental impacts that we're seeing both during virtual schooling and hybrid schooling and at-home periods in the last 2 years, where we have seen that health habits of kids have been very poorly affected. And we know, and there's a lot of studies comparing in-person and virtual schooling and what the impact of that was, not just on mental health, but related and connected to that on physical health, on physical activity, exercise, diet habits, sleep habits. All of those things have been impacted in our kids, and all of that does contribute to how their mental health is. Social isolation and a lot of the mitigation strategies that we have been, needing to employ to stay safe and to stay afloat have had an impact on all of us and our kids as well. And particularly, kids in certain stages of development are particularly sensitive to that social isolation and the resulting impact on mood, losses of various milestones of relationships, of events. They do contribute and are factors in our kids' stress levels, and certainly we've seen an impact. Technology itself could be an entire lecture or a full day workshop, and how that impacts on kids. And again, we've known this before the pandemic. Now through the pandemic, our kids have spent even more time on devices. And not just are they spending more time, they're also spending more unsupervised time and more time on areas of the internet that perhaps parents have no insight into what kids are spending their times in on the internet, and what exactly are they being exposed to, and how's that influencing them and their relationships and their self-esteem and everything else that we are learning about how technology use and social media is impacting on our kids. And then as with everything, and as we see this on the medical impact, this is true for the mental health impact, the risk of impact is always higher for vulnerable population, because every single one of us, adults, kids, have been impacted in the last 2 years by stress. And that impact of stress varies day to day. But people who are at risk, who were maybe having existing pathology before, or were at risk for developing that pathology because of family histories, let's say, or have been in situations or have been subjected to such stresses that there's situational new development of new symptoms. And then really being impacted by the whole issue about accessing care, and accessing care for mental health in particular was, again, challenging even before the pandemic, but has been incredibly so since then. So to really just give some practical guidance and hope, because it is so easy to get lost in all the anxiety and the stress and the anger that we're all feeling about the situation and about the difficulties that our kids have to endure, and all our worries about the long-term impact, which admittedly we don't really know yet. We don't really know how this is going to play out in the future for kids. But I do think it's important to talk about what can we as parents really do about our kids and mitigate the impact of this ongoing stress circumstance that they're living on, and how do we put very conscious, consistent effort that it requires to raise resilient kids and to help them stay resilient despite of the many things that we cannot control in their lives. And regardless of, what your view is on, any of the hot topics of the day, regardless of where your stresses as a family are coming from, it is always really important to follow these basic principles that kids need to be able to stay resilient, because kids really rely on us adults. And there has been a lot of research studies that show that really in the family and in the core family is where a lot of this work is really able to be done to give these core 3 main pillars of structure that you see here, of structure, support, and encouragement to your children to allow them to be able to stay resilient. And what does this mean? We all know kids need structure. During COVID, their structures have been shaken. So really important to put conscious effort into adjusting routines, redeveloping routines, having consistency in kids' lives, clear communication about issues, clear limits that kids need, and having a balance between being available for our kids, and we'll talk about support, being available and having that secure bond, having an environment where our kids can bring concerns and their fears and their anxieties to us, but then also providing them with consistently structure and limits at the same time. And then support is hugely important. And our role there is really to help, do a lot of modeling. And I think if you take away one thing from tonight, from at least my piece of mental health and what you can do for your child's mental health, that is to take a look inside and see what you're doing for your own mental health and your own stress management, and how are you modeling managing emotions, how are you able to model problem solving, helping kids to label emotions, helping kids to understand that you support and validate their feelings, that even as parents, even if we don't agree with the behavior, a decision our child makes, we can really understand and empathize and validate how they're feeling in that moment, or why they're acting the way they're acting, and understand when you're more support than you can provide, and then how to get that for them. And then encouragement is hugely important, because kids need to be pushed to try new things. Kids need to learn to take risks. We have shifted in recent decades into really protecting our kids from everything, and really preventing them from having those difficult experiences that allow them to learn how to manage and problem solve, and helping them learn, not solving the problems for them, but helping them learn problem solving, and helping them really understand that difficult situations and can really result in growth, and having problem solving and encouragement in their life, and modeling of that on how we approach the difficult situation that we're having. And my computer is acting up. But how can we resolve the difficult situations that we're having can really help them approach then those situations themselves, and really helps yield more resilience in our kids. Along those lines, there was a question submitted that was asking about, how to prepare kids for the various changes that are happening, whether it's relating to masks, or relating to this ever-changing risk-benefit analysis that is happening with adults every day, and shaping policies and shaping rules, and how do we help them prepare for that and navigate that. And as always, the answer really is to follow these core values of consistent communication, providing an environment where kids can bring concerns, where you can validate, where you can start with what they understand and really listen to them, listen to their concerns, and be able to provide them with information, help them manage and understand that even though there's a lot of things that we can not control in our current world, there are many things that we can, and those are things to focus on, things that will make us feel safe, thing that helps us calm and relax and get a moment of stepping away from all the stress and getting those periods of rest for our brain that are so important. Having connections in our lives as the third really important component, and then teaching our kids how they have grown and what they have learned and how far they have come during this period of time. And again, using difficult moments and difficult periods or things that cause us as adults a lot of anxiety, opportunities to teach and learn coping and managing difficult emotions together with your kids. So I'm going to stop there because I don't know if there's a couple more questions that we quickly want to go over. So I'm going to hand it back to Gina Marie.
Thank you, Dr. Foyer. I think you grabbed our one question there pertaining to behavioral health. So I'll go on to the second question. Thank you to all our panelists for sharing their experience and knowledge. Dr. Fegan, so we had one panel question come in tonight that says, what studies have proved that any of the emergency use SARS-CoV-2 injections, I'm going to assume that they're referring to the vaccines, prevent transmission? Are you familiar with any of those studies, or is that just something that's in the vaccine trials that haven't seen yet?
So it's a good question, and thank you for whoever submitted that. So the vaccination is to prevent serious and significant symptoms in the individual. So you can be asymptomatic and still potentially transmit any virus, not just, SARS-CoV-2. It's the same thing with the flu. And that's why we talk about all these other mitigation strategies, from hand washing to social distancing to mask wearing in, public indoor settings, et cetera. So that's what we know can reduce transmission. And I'll just refer back to last year's flu season. When we didn't have any flu, we didn't have any of the really common childhood viruses that crowd our pediatric offices every year, because all the layers and strategies that were put in place. So thank you.
Great, thank you. So I know we're just about at 8 o'clock, and we have answered all our questions that came in tonight, and all the ones that were pre-registered we put into the presentation. So I'll give all our audience a couple of seconds to submit anything else they want. If our panelists want to give any last words, although again, presentation is your expertise. One more second.
I just maybe want to add.
I do have a very good.
No, I was just maybe want to add, to end on a positive note, that we always talk about all the negative impacts, but there are, you know, we don't know a whole lot, but there have been some positive impacts on families and on the way that people connect to each other. And I think it's really important to remember that, and really important to sort of use that as our anchor on how to go forward as we all, as families with our, you know, kids and our communities, navigate these very difficult waters, because I do think that can, you know, looking at it as a reset and looking at it as something that you can grow from can really help us adults navigate this circumstance. And ultimately, that is what's going to help our children, again, just mitigate and get through this and mitigate the stress and the mental health impact.
Great, right. There's always that positive silver lining, you know, through it all. I did acknowledge that before COVID, we had a crazy life of just basically driving our kids from point A to point B, all 4 of them. And then I felt like it was God's time out. And we actually spent a couple of years together as a family. And we actually never went back to that craziness. So that would be my silver lining that I appreciate. So thank you for pointing that out, Dr. Foyer. So thank you again to our panelists, Dr. Fagan, Dr. Williamson, Dr. Capone, Dr. Foyer. You know, what we always like to say in healthcare is we hope we never see you, but if you ever need to come in, we're always there to help you. So thank you, everyone. Have a wonderful night. Take care. Be well.
Thank you.